Hello everyone, my name is Parul and I'm pleased to welcome you to today's MHS webinar entitled From Broad Stroke to Fine Lines, Effective Use of Psychological Tests presented by Dr. Sam Goldstein. This webinar is part of MHS webinar series ADHD Uncovered Strategies for Supporting Youth and Adults. We are thrilled to have you all here with us today, and we would like to begin by telling you a bit about MHS Clinical and Education divisions. MHS Clinical specializes in aiding the identification and treatment of psychological disorders for improved patient outcomes at all stages of life. MHS Education specializes in providing the expertise and resources required to help children and adolescents reach their full potential in and beyond the classroom. With our advanced suite of tools, team of experts, and robust data sets, we help clients provide comprehensive evaluations and uncover powerful insights. Now, without further ado, it's my great pleasure to introduce you to our presenter today. Dr. Sam Goldstein obtained his PhD in school psychology from the University of Utah and is licensed as a psychologist and certified school psychologist in Utah. He is also board certified as a pediatric neuropsychologist and listed in the Council for the National Register of Health Service Providers in Psychology. Dr. Goldstein is a fellow of the American Psychological Association and the National Academy of Neuropsychology. He is an assistant clinical instructor at the University of Utah School of Medicine, Department of Psychiatry. Dr. Goldstein has authored, co-edited, and co-authored over 50 clinical and trade publications, 6 textbook chapters, nearly 3 peer-reviewed scientific articles, and 12 psychological and neuropsychological tests. He is editor-in-chief of the Journal of Attention Disorders. Since 1982, he has served as Clinical Director of Neurology, Learning and Behavior Center in Salt Lake City, Utah. We are so glad to have you here with us today, Dr. Goldstein. As we begin our presentation, I again would like to quickly remind you that there will be a survey sent to you in order to satisfy CE credit requirements. If you do not receive this email before the end of the session, then please send us an email at marketing@mhs.com so we can send it to you. Now let's start the webinar. Over to you, Dr. Goldstein.
Thank you very much, and thank you for that very gracious introduction. One correction, I am now the former editor of the Journal of Attention Disorders. My tenure ended just a couple of months ago, and I very much appreciate that introduction. And I say good day or good afternoon, or perhaps to some of you even good evening, and thank you for joining us for this session today. When I decided to be a psychologist, my thought was that my job would be to visit with people and try and understand how they feel or what they're thinking, help them identify what problems they have, and hopefully lead them to solutions. And very quickly, I decided I liked children better than adults because the children were more likely to let you see exactly who they were. They weren't as well defended. And when I first started, I had been a researcher, and then I decided to shift. And in the early 70s, so that's a long time ago, it's 50 years, we didn't have a lot of tests. And a lot of what we determined or what we decided was based on inference. We would infer things. The proverbial clinical judgment, which in some circles is often beaten up. How good is our clinical judgment? How easily can we be fooled? And the process of assessment, I'm fortunate, having been through this 50 years, that started with an inference, one or two very simple kinds of tests, the early Wechsler, for example, the earliest questionnaires, those of Dr. Connors or Dr. Achenbach, were fairly simplistic as we look back on how we gather data. and how we form hypotheses and how we draw conclusions about the significance of that data. But one thing hasn't changed. What hasn't changed is that this process that we engage in, this process of evaluation, uh, whether we're administering tests or drawing inferences or looking at ink blots, what hasn't changed is the goal of trying to understand and experience the life of another individual, to appreciate their mindset, their thoughts, their feelings, the variables that impact their behavior, and then, of course, to use that data uh, to make a difference. And over the years, there have been periods of time where the focus has been in a very limited way on trying to apply the data we collect. I'm very happy to say that definitely in the last 10 or 15 years, there's been an increased focus on how do we use the data we collect, not just to determine eligibility in the schools or make diagnoses in a clinic setting, but how do we use that information in an affirmative way to make a difference for individuals. And this talk will not focus on the intervention, although it's become a very popular topic to look at research demonstrated interventions versus those that just sound like good ideas. So as we talk today, my focus will be on how we get from that first step, what's the problem, to a definition and a delineation in a reasoned and reasonable way of what is or what are the problems, what variables define them, and increasingly, what assets does the person have? And that most of us who trained were trained in finding something wrong, the psychopathology of the human being. Very little time was spent on what was right. We took a course in development, but then quickly moved to clinical courses whose goals were defining the different, defining the adverse, and ultimately providing diagnoses. And I'm pleased to say that now we understand that assets are as important, if not more important, in the process of an evaluation as are identifying and measuring weaknesses. So let's venture into this. I have a lot of information. My slides are made available to you as a handout if you want to take some notes. I will always be available to answer questions. You can see my email there and some of my social media. There's that TikTok at the bottom. There's a lot of controversy about TikTok. We can talk about that another time. For me, it's been a place where I can make comments about some of the irrational, maybe even stupid ideas that are professed as clinical science or psychological science, and that's my TikTok at Common Sense Science. So here's my disclosure. We do that now so that everyone knows whether we are being compensated by someone. I do receive an honorarium from Multi Health Systems. I'm very proud to say that this is my 20th year of being affiliated with MHS, maybe more, but I think it's 20. When I first approached MHS about an idea I had for an instrument that could, in a reliable way, measure the behaviors and symptoms and associated problems of children with autism. And since then, it's been a wonderful relationship. We've developed multiple tests, Jack Neglieri and I, and we continue to work with MHS. There's more to come. I have developed tests with other companies. I have a new instrument with Jinty that is just coming into the marketplace. We won't talk about that today, but it measures mood disorders, dysregulation, DMDD, and dysregulation of mood in children, which for the first time has been standardized. We've collected data to look at what's normal and how do we measure the associated problems. I've authored, as mentioned, quite a few books. My most recent scientific volume is an edited volume for clinicians published by Springer on disruptive mood dysregulation disorder. It's the first book for clinicians on that topic for school psychologists and general psychologists as well. Our new trade book, it's been out a while with Bob Brooks, Tenacity in Children, explores the 7 instincts that make us human. And we have a new children's book, Bob and I, called Poppy and Graham's Quest for Tenacity, and it's a graphic comic. I enjoy writing and have a number of books that we are still working on. In fact, one of them might intrigue you. Bob and I have started work on a book on rivalry, jealousy, and competition, and the subheading is Harnessing Your Basic Instincts for Happiness and Success. So we're looking at those behaviors through a different lens. So today, I have a series of goals that you can see. I want to talk a little bit about what we do. And I started that in the opening of our discussion. What do we do and why are we doing it? I want to talk a little bit about the foundation of that assessment, which is what is development. Many of you spend your careers focusing on determining eligibility, not necessarily making diagnoses. We'll talk a little bit about prevalence and comorbidity, and then a framework for assessment and look at variables that I think make a difference in assessment. Because again, our tests are not given in a vacuum. And I'm reminded of one of the first children I evaluated in my training, and I was asked to give a WISC. So this is the WISC 1. That's how far back it goes. And I took out the test materials. Of course, we can all remember the first few children we evaluated for real, not our kids or nephews or nieces, but for real. And my supervisor was watching through the one-way mirror, and this boy was fidgeting around. The referral was, of course, he was hyperactive and inattentive. We call that hyperkinetic reaction of childhood then. And I couldn't get him to stay focused. But out of the blue, he pulled a pack of baseball cards from his pocket. And he held them up and he asked me if I liked baseball cards. And for a minute, I was pushed to tell him to put them away. But something in me, maybe the researcher in me, responded, "No, I don't know a lot about baseball cards." At which point he told me he would teach me. And he began laying the cards on the table. His body stopped moving. He sat in the chair. He seemed focused. He wasn't impulsive. He made eye contact. He asked me questions. He told me about each of the players and what information is on a baseball card. After about 5 minutes of this, I realized that we weren't getting anywhere in the testing. So I asked him to put the cards away, which he compliantly did. But of course, he went right back to this restless, not necessarily oppositional, but restless, inattentive behavior. In the end, my supervisor admonished me for letting him go on with the baseball cards for too long. My response was, I learned more in that 5 minutes than I did in giving the Wechsler about this child's temperament, and the fact that when he was engaged in an activity that was of his choosing or that he enjoyed, he focused a whole lot better. And maybe that should be part of our assessment. Of course, my supervisor at the time didn't like that response. Here's what I want to do today. Many of you are experienced, you've been in the field, so some of these ideas you already may be comfortable with. Some may be new for you. Some you may not agree with. But I want to get you to think. I want you to get you to think about what is it we're trying to do when we evaluate a child. And it's not just as simple, we're trying to determine if they're eligible or not eligible. And it's not just as simple as we're trying to decide if they meet a certain diagnosis or not. And we'll talk just briefly about the diagnostic system. Maybe I'll bring it up right now as we're getting started. Keep in mind, this diagnostic system we use, the ICD, which is the World Classification of Diseases, or the DSM, this system is polythetic. Polythetic. It means that you have a variety of symptoms to choose from. It's like a Chinese restaurant menu, 2 from column A, 2 from column B. The assumption is that every symptom on the list that was given positive predictive power has equal ability to tell you something about the future, and that couldn't be further from the truth. The fact of the matter is some symptoms are fairly benign and some are very predictive of future risk, but algorithms, for the most part, don't fit in the DSM system. And so when in an evaluation, you're trying to take this list of symptoms and determine how many of them the child meets, and if they cross a certain threshold, then they receive the diagnosis. And it's interesting, but not particularly scientific, and statistically not particularly good. Why do you need 6 out of 8, or 6 out of 9, or 2 out of 3? It's a fairly arbitrary system based on pretty limited scientific analysis, as far as I'm concerned. Now, the eligibility criteria is a little different because Fred Weintraub, who was the godfather of special education, and I had the pleasure of working with him on the reauthorization of IDEIA, Dr. Weintraub's goal was to not create another DSM in the schools. And his goal was to create criteria for which you either were or were not eligible, not a list of symptoms for which you met so many to determine eligibility. You either met criteria or you didn't. It wasn't meeting part of the criteria, but all of it. And so that's why we talk about eligibility in the schools. Are you eligible under a certain category to receive services? There's been a lot of debate, for example, with learning disability. How do you create that eligibility? Is it by a discrepancy? Is it by an average person standard? There's been discrepancy in the behavioral and emotional diagnoses. Does it have to disrupt your school performance? If you misbehave in school, but you're earning good grades, do you qualify, etc.? There are questions that are still debated. But the bottom line, our work together is to determine eligibility or make diagnoses. And again, as I pointed out, that's a step along the way because I want to know why you received the diagnosis and I want to know your strengths and weaknesses. So we're going to look at a framework. We're going to talk about broad and narrow band tests, which fits that framework. You start by asking general questions, and you eventually ask more specific questions based on the answers to those general questions. We will talk about a number of tests. Many are published by MHS, but not all. And we will not explore all tests. We're not going to talk about academic measures today. We're not, for the most part, going to talk about intellectual measures. For the most part, we will talk about questionnaires because they have become the gold standard. And we will also talk about a framework for how I think, and Jack Naglieri, my colleague, and J.P. Das think. Ultimately, the work that began with A.R. Luria, how the brain works, how children learn, and how they function. We'll talk a little bit about how to choose tests and a decision-making process. And hopefully we'll still have some time at the end for some questionnaires. So I alluded to this idea that we start with the general. When I meet a child, I do the bus test. Have you heard of the bus test? Probably not, unless you've heard me speak before. But I ask myself, if I was on that bus sitting next to this child, could I do it? And if so, how long could I sit there? And on a bus, children can exhibit two kinds of problems because, again, the first diagnoses in children were based on how the child's behavior affected us, not necessarily how it affected them. And on the bus, the child can exhibit one of two problems. They either behave in a way that disrupts and disturbs me. They're restless, they're impulsive, they're oppositional, they're aggressive, they're threatening, whatever the case may be. Or they can behave in ways that worry me. They seem anxious, withdrawn, depressed, insecure, unhappy, whatever the case may be. And the first group we call disruptive, and the second group we call non-disruptive. Again, I think the irony is missed on a lot of people, that these early diagnoses were based not on the child's issues, but on how the child's behavior affected us. Those of you who use the Achenbach are familiar with the disruptive, non-disruptive framework that Achenbach pioneered. So we'll look at these two continuum, but first, let's take a slight detour. I had a revelation in St. Augustine about 35 years ago. I hit my head on a door jamb, and I realized that people were very short then, and so doorways didn't have to be very tall. The world operates on a bell curve, on a normal curve, and that's pretty much how we operate in making diagnoses or in determining eligibility. Where are you relative to everyone else? I'll ask you to consider that your place on the bell curve, if you're way down at the base of the bell curve, the beginning of the curve, everyone can do something you can't, you have a problem. And if you're at the other end of the curve, you can do things that others can't. If they're good things, like critical thinking, then you have an asset that others don't possess. So I think it's important for us to appreciate the instruments we use should provide a foundation of comparison to that normal curve. That we shouldn't be using instruments that are standardized on 25 kids from one neighborhood, but rather instruments that reflect the census and as best we can are standardized on the general population. That's a change that's taken place over the last probably 30 years, a recognition that it's not enough to ask questions about a child. One has to then take those answers and put them into some kind of a metric to compare those answers to what? Do you compare them to the kid up the street? Do you compare them to the kids in that classroom? Do you compare them to kids in the school district, in the state, or perhaps in the country or the world? And I think as we look at all of these instruments, one of the consistencies between them is they very closely match to the census, so that you have some confidence that what you are measuring and the conclusions you draw are valid and reliable. So here's how I was trained, and I apologize the way this has come up here, but all children share qualities with each other. And all children have qualities that are unique to them. And all children have qualities that we would consider adverse that put them within certain subgroups. And I will argue that as clinicians, the majority of our training was on that last group. But I will tell you that my evaluations, and I do about 200 evaluations a year in the clinic here. We do about 800 a year. And I will tell you that I now make equal space to discuss the child's strengths as their weaknesses or liabilities. And I also make an effort to at least comment and appreciate that there are certain qualities about a particular child I'm evaluating that really doesn't place them at a whole lot of difference from others. You know, I sort of learned that the hard way because as you take histories when you begin your career, the level of the child's problems are often reflected through the eyes of the parent, sometimes the teacher. And I had a parent who was telling me as I took a history about their child's, inability to, sit through a meal. And as I watched, it suddenly dawned on me as I watched Dad fidgeting around, I asked, well, does anyone sit through a meal? And Mom said, much to her chagrin, no, nobody will come to the table and sit through a meal. And I didn't offer any opinions about what it was about the mother's cooking that maybe drove that. But the bottom line was this child was not any different than their siblings, or for that matter, their father in this family. And yet I see other families who can't understand why this child can't sit through an hour meal and the child's, 4 years old. Well, that's not normal. So again, I think comparison with the norm, comparison with an understanding of what is typical and then an understanding of strengths or assets. Because again, when children transition from childhood to adulthood, when they leave school and venture out into the real world, no one asks them their worst subject or their most annoying behavior. Nobody really cares. And when we look at outcome over time, this discussion today is not focused on that, but when we look at outcome over time, it isn't liabilities that best predict affirmative outcome. It isn't liabilities that best predict affirmative outcome. And that is children who have liabilities, the best predictors of good outcome for them isn't the liability or the treatments for the liability, which may lead to symptom relief, but in the long run, the best predictor of outcome is what's right about a child. And children who transition into adulthood and manage to find functional life with ADHD, for example, or other childhood disorders, do so not so much because their ADHD is managed, but because they have other strengths that they can bring to the table to help them find normalcy in life. And as psychologists, I mentioned a minute ago, and again, I'm jumping around topics here just to lay some foundation, that everything we do is on that bell curve, right? You take a history, even the history, if you use a form like Mel Levine's, Mel's been dead for quite some time, but he had this history form you could score. There are other history forms you actually can generate scores for, and you do it based on a dimensional view. But everything we do, the tests we use fall on a bell curve. The way we evaluate the benefits of our interventions fall on a bell curve. That's all dimensional. You know, the only thing we do that are categorical, all or nothing, all bets are in, is the diagnosis or the determination of eligibility. That's it. And none of us like it. We don't like being in a team meeting and having to tell a parent that their child is just short of being eligible for services. We don't like a meeting after a clinical evaluation and telling a parent, yes, your child has social pragmatic problems, and yes, they have some repetitive behaviors, but their challenges don't rise to a level of a diagnosis. None of us like that because we are, in effect, dimensional evaluators. And I don't mean three-dimensional, I mean dimensional, and as in we appreciate for everything we do that we generate data that is within the framework of understanding where that person is relative to a normative sample of others. And it's much easier to talk to a parent about certain weaknesses in behavior in social pragmatics, for example, or in attention to detail or impulse control. It's easier to explain that to a parent in a dimensional way and then focus on how does that cause impairment, because you have to have impairment. If you have symptoms and no impairment, you don't get a diagnosis. That's just called behavior. Again, a symptom is a behavior that's part of a diagnosis. Not all behaviors are symptoms, but all symptoms are behaviors. This is the disruptive continuum. Let me go back. This is how I look at it. Difficult temperament. Remember Chess and Thomas or Carey and their assessments of temperament. There was a time when we screened young children, for example, coming into kindergarten with a temperament evaluation, understanding their level of restlessness, their level of irritability, their tolerance for stress, etc. And what starts as difficult temperament now transitions to attention deficit, right? So as the child enters school, the kindergarten teacher is prone to say, the child's had a bit of a difficult temperament there. They're not always sitting still, they run around quite a bit. But by first grade, we change our terminology. We'll discuss the fact, for example, that this restless behavior could be part of a syndrome of attention deficit. And then for some kids, that can progress to oppositional defiance, which simply means you're prone to say no in an impulsive way. And oppositionality can occur for a lot of reasons. You could be rigid and see the world in black and white, and when you think it's black and somebody else thinks it's white, you're going to be resistant to that. So not all children start with difficult temperament and progress through this continuum. Some come in at different spots, for example. But it's a common stream. If you look at Ralph Lober's research from Pittsburgh from years ago, this is a common stream of difficult temperament leading to symptoms of attention deficit, fueling patterns of oppositional behavior, and finally conduct disorder, which is a selected group of status and non-status offenses. You understand a status offense is something that a juvenile gets in trouble for that an adult doesn't, like drinking. So there is this road. A high percentage of kids with difficult temperament end up with a diagnosis of attention deficit. A significant percentage of those end up with oppositional defiance, and a significant minority of those end up with a diagnosis of conduct disorder. And I'm prone to say that if you pick an example, Robin Williams was a good example of the frenetic behavior sometimes of someone with attention deficit. I'm not diagnosing him. Clint Eastwood, in his Make My Day statement, is more characteristic of oppositional defiance. And James Dean, a rebel without a cause, is more characteristic of conduct disorder. Here's the non-disruptive continuum. It's really not a single road, but temperament and, of course, development lead to depression and anxiety, which we'll talk a little bit about. But to lay some foundation, depression is a sense of hopelessness or helplessness. Anxiety is a lack of confidence in predicting outcome. In large-scale population studies, it's rare to find someone who's worried, who doesn't feel helpless or hopeless, or vice versa. The same medicines treat both depression and anxiety. Same parts of the brain, same neurotransmitters are implicated. And the same kind of atypical thinking is associated with it. In many ways, depression and anxiety are really two parts of the same phenomenon, but they've been partialed out. And then learning and social problems, we'll talk a little bit about how we who follow A.R. Luria look at the challenges to learning, and then social problems, which include social pragmatic problems that are characteristic of autism. So how do we define these things? What do we say? And I apologize for my little cough here. I'm not ill, but I seem to have developed a cough in the last couple of days. How do we do it? Do we do it by cause? Again, determining eligibility or diagnosis isn't based on cause. You don't have to know the cause. You just have to measure and observe the behavior. Do we do it by the behavior, the emotion, the ability, the thought the person reports? Or do we do it by impairment? And there is an increasing push to do it by impairment, not either one of the other two. Impairment in everyday functioning, impairment in school performance, impairment in acquisition of academic knowledge, impairment in socialization, meaning a deficit in how you go about doing what you do. Why is impairment a better way to do it? Before 1987, you could make a diagnosis of ADHD in an adult, even if they had no impairment. Didn't make any sense, especially at the rate at which diagnosed disorders are increasing in the population. So now you have to have impairment. You can't just say you're inattentive, hyperactive, and impulsive, and therefore you warrant a diagnosis. If you don't have impairment, you don't warrant a diagnosis. In some ways, eligibility determination is based on looking at impairment, whereas the DSM is more likely to look at emotions, behavior, thought, not necessarily underlying cause, although conditions like PTSD require a diagnosis that includes causation. You can't say someone has PTSD, but we don't know why. So what is a diagnosis? Again, I think it's, if you look at the sort of the determination of it, you examine someone and you reach a threshold, a category that says you fit this. What is eligibility? Well, there's a dictionary term. There's a lot of different terminology for it. But I think eligibility is more about crossing a threshold in which you're entitled to support, which is why I think impairment is more a determination of ineligibility than a diagnosis per se. And I think a lot of schools, I could be wrong because I'm not in the schools and I'm not visiting as many states as we did pre-COVID to speak and find out what people are doing in different states. But in some states, like in Utah, you could be served in the schools as eligible under autism in the IDEIA and yet not meet full autism criteria in a clinical setting, which is often confusing to people because the same term, autism, is being used. Now, this is old data, and I went looking for new data, and I didn't find anything I liked as much. But again, the prevalence, here's prevalence of mental health challenges, by far depression and anxiety. This is incidence, which is how many people have it at any given moment. And this data looks at, I said incidence, meaning how many have it at a given moment. This looks at prevalence, how many have it over a measurable period of time. And again, anxiety and depression are clearly high. This is well before COVID, and we know since COVID, these statistics have changed. Now, the question is, how distinct are these disorders from each other? Here's a National Institute of Mental Health. This is almost 20 years ago. And you'll notice that as we're looking more at gene markers, we're finding that the nomenclature we have may not fit as well in terms of gene markers, that there may be more similarity between some conditions by genetics than by behavior. Here's a more recent comorbidity chart that I put together from a number of studies. And so the statistics there show you, for example, the left column, the diagnosis autism spectrum, then you go across and you see its overlap with ADHD is 60%, right? And then if you start with ADHD, go to ASD, it's 60%. But look at the overlap of these conditions. Look at the overlap of depression and anxiety. I mean, if there's such overlap, are these really distinct conditions or distinct disorders? Think about the children you work with clinically or in a school setting. What percentage of those being served as eligible for autism are also taking a stimulant medication for ADHD? And I would argue it's a very high percentage. And that's because both in our census match studies for the ASRS and in others, at least 60 to 70% of children with autism meet ADHD criteria. So if there's that high an overlap, then the question remains as to whether or not you make two diagnoses or whether those behaviors really are part of autism. Again, these are still unanswered questions. And I had a lot of slides, and if you go on my website to a longer presentation of this topic, and you scroll down my slides, you can download the longer versions. I had a lot of studies that look at a comorbidity or co-occurrence. Comorbidity means that two things occur together. And this one has always been of interest to me This is a 2012 study, but kids with substance abuse typically have other psychiatric disorders. We like to say they're either impulsively abusing, they can't stop, or they're just lubricating their unhappiness. Either way, the condition, the substance use, is a reflection of their mental health challenges. So how distinct are these things? This is a study that's about, I think, 6 years old or so. What the problem is with the DSM. These are not very distinct conditions from each other. And a consensus is the way they started. The first DSM came out 1952, the year I was born. It was about 40 pages, nothing about kids, because at the time the thought was kids' super egos were not sufficiently developed for them to experience mental health disorders. They could be unhappy, they could be angry, etc., but it didn't rise to the level of a disorder. We have, in a sense, pathologized everything about ourselves and our children, so now it's not uncommon to give 2-year-olds multiple psychiatric disorders. So again, not very distinctive from each other, highly polygenetic, meaning not one gene, and at a genetics level, no sharp boundaries. Where's the line between normal and disordered? And those of you that have worked with families, and I routinely ask mothers and fathers to fill out questionnaires, you get very different observations of the same behavior. Do you do that with teachers in middle and high school as well? The line blurs between what's normal and what's not normal, often in the eyes of the reporter. So comorbidity is the rule, not the exception. So I lay that out as a foundation to say, if you start your assessment for eligibility or for diagnosis, whatever the case may be, you start your assessment by saying, I'm evaluating for ADHD. I'm evaluating for autism. You have a problem, because then there's a tendency to not consider alternate hypotheses, but even more troublesome, there's a tendency to then see all symptoms as related to a particular condition. And since symptoms overlap, it's an easy mistake to make. So if you're asking, I suggest you start with, tell me, what concerns do you have for this child? I suggest you start with making a list of those that are disruptive and a list of those that are not disruptive without any effort to fit them into a label. You got to start with the narrative and work from there. So why are we evaluating? And I think I've already pointed this out. Yeah, we want to know symptoms. We want to know strengths and weaknesses. We want to know if some of these are predictive of each other and load into a unitary condition. And we want to know levels of functional impairment, because it's the impairment that forms the baseline for the assessment of whether what we're doing is making a difference. I'll give you an example. Not long ago, I worked with a teenager who was very depressed. And as this child started on some medication, we began working on a CBT model of understanding depression for teenagers. And after a period of weeks, he reported to me that he wasn't as depressed. He was feeling better. And I said, well, feeling is one thing. How are you doing? Have you gone back to school? No. Have you seen any friends? No. Are you coming down to have dinner with your family? No. So the symptoms were better, but the impairment hadn't improved. And functional impairment is really the target of what we're looking at. I think a comprehensive assessment has to start with a history. It's hard to get a history in school settings. Psychiatry, that's basically all they do is take a history and then apply the diagnostic criteria. Leaving out the related steps, I think, increases error variance. I always start with a broad spectrum questionnaire. Since Dr. Connors was a mentor of mine, and since I've worked with MHS, I use the Connors. We'll briefly talk about both the Connors 3, the early childhood Connors, which I think is the best early childhood tool available, and the Connors 4, the new disruptive behavioral Connors. But you could start with another. You could use the Basque, you could use the Achenbach, but you have to start with a broad spectrum questionnaire. Partly just for ease of administration, you can't give parents 10 questionnaires in an effort to rule out certain conditions if they really don't show up in the screener. And there are self-directed questionnaires, the diagnostic inventory of children's disorders that a patient or a parent works through on their own. It's a lengthy process. It takes a couple of hours, and it just basically uses the DSM symptoms. It doesn't use a standardized instrument per se. And I think the second thing beyond the broad spectrum tool you have to look at is impairment and risk. We've slowly started offering questions about risk. What's the risk that the way my child presents, they're going to receive a diagnosis or they're going to have trouble later on? And we look at executive functioning, which has become popular, but it really is important because you could have symptoms, but if you have good EF, if you manage your emotions, if you're efficient in attention to detail or planning, it will reduce the adversity of your other symptoms. So it's important to understand that. And I'll talk about one tool that I developed, the RISE with David Herzberg, that actually looks at interpersonal and within person strengths and weaknesses. And then you got to look at narrow spectrum questionnaires. We'll talk about those. Some self-report measures. Some look at ability, which again is the neuropsychological aspect of it. Some look at achievement. Ability assessment is used to explain in part level of achievement, and then talking to the child or student. Now, there's a whole bunch of critical issues here, and for time's sake, I just want to mention them briefly, but I want you to keep them in mind when you do your assessment. One is demographics. Who's the population you're working with? Because I've had teachers tell me for a child that I'm evaluating, he's not so bad, and really what they're doing is comparing that child to 2 or 3 other kids in the room who are far worse. So you have to know your demographics. And what's the population you're looking at, both in ethnicity and socioeconomic status? It's an important variable. I think you have to understand symptoms versus consequences. A consequence is something that occurs because of a symptom. So not finishing your homework isn't a symptom, but poor impulse control that leads to not finishing your homework is a symptom. We discussed categories versus dimensions earlier on. We've discussed eligibility versus diagnosis. I think you have to accept a moment in time, a developmental pathway per se. Your assessment tells you where the child is. I tell parents, if we want to know what your child is going to be like when they're 8, if we want to know what they're going to be like at 16, we'll wait till they're 15 and a half. Our assessments are moments in time. We can make some predictions about need, about outcome, but for the most part, you got to wait and see what happens. There are also no shortcuts. And the environment I mentioned earlier, the family who has unrealistic expectations for the child versus the family who has more realistic expectations. We talked about assessing for intervention. I briefly mentioned positive and negative predictive power. So in case you've forgotten, positive predictive power is what's the probability that a certain symptom or behavior predicts a diagnosis. Negative is what's the probability that absent that symptom or behavior, you won't have a diagnosis, right? Positive and negative predictive power. The other issue is sensitivity and specificity. Sensitivity implies I want the instrument to catch everyone with the problem, so I'll make myself sensitive even though I'll get false positives. Specificity decides that I only want to identify people who really have the condition, and therefore I'm willing to have some false negatives. If you want to be more sensitive, you have to appreciate you're going to identify more people and have more false positives. If you want to be more specific, if you only want to identify those who really have the problem, you're going to miss some whose problem is true but mild. And everything we do balances sensitivity and specificity. I argue we should be sensitive in understanding the journey of the child or the individual, understanding the challenges they may be experiencing, but we should be specific in assigning labels or in determining eligibility. We should be sensitive in offering help, and we should offer help even if someone doesn't meet diagnostic criteria. I think you got to understand the disruptive and non-disruptive continuum. I think you have to keep low incidence problems in mind, things that don't present to you very often, particularly certain genetic disorders like Fragile X. Most school psychologists may see a few of those kids in their career, but you still have to keep it in mind and be aware of the common genetic disorders that lead to emotional and behavioral and learning problems in children. I think you have to consider protective factors. I think you have to measure impairment. Again, impairment is the functional problem you have. Well, let me see if I can give you a sort of a pathway to that. I measure symptoms, and I discover on a Connors questionnaire a child is quite inattentive, not necessarily oppositional, a little bit anxious, to the point where I'm concerned. I then measure executive functioning, strategy behaviors, and I discover that this child has reasonably good ability to regulate emotion, to start when they're supposed to start, to be reasonably organized. And then I measure impairment and discover that despite the fact that this child has symptoms that may come close to meeting a diagnosis, the child's average or better executive functioning reduces the adversity of those symptoms in predicting impairment. Does that make sense? So two children can have the same level of symptoms on a broad spectrum questionnaire. One might have good EF, the other poor EF. The one with poor EF is going to have a lot more impairment. The symptoms will much more likely adversely impact their everyday functioning. And I think it's something you have to keep in mind. I think as you evaluate, you want to make a distinction between acute versus chronic problems. I just evaluated, I do a lot of forensic work, a child who had a brain injury, and the evaluator on the other side determined that the child's test performance reflected their lack of compliance, pre-existing issues, every possible explanation other than, no, this is an acute change as a result of a brain injury. So I went back and I analyzed this child's report cards and the narratives the teachers wrote in the report cards, and built a case to demonstrate there was an acute adverse change in this child. His problems have a specific time of onset and a specific causation. This is not a chronic problem, and we hope that as the child recovers, it will not become a chronic problem. So I always address with parents, is this something the child's always had trouble with, or is this something with a more recent onset? I think you need to understand protective factors. You've heard me speak, you've heard others speak about resilience, and I'll just briefly touch on those factors. I think your assessment should be strength and risk focused. I think in your opinions, whether you're writing about eligibility or diagnosis, I still think there should be a section of your report that discusses strengths, not just weaknesses. And I think you have to present the data in a way that people can understand. I do a day in the life. And as I talk to parents or teachers, I do a day in the life of this child based on the information we've collected. What is it like from the time they get up till the time they go to bed? What abilities do they bring to the table? What knowledge do they possess? What is their mindset about friends, about school, about family, etc.? I want everyone involved. I want all the stakeholders to see the world through the eyes of this child, if that makes sense. And that's how I try and present the test results, not in a lot of scores and bell curves, but rather in a common sense way that lay people can understand it. And for me, it's always the least amount of assessment needed to answer the referral questions. Again, the kids I see are fairly complicated. Half the kids in our clinic have brain injuries. So I see very complex kids with genetic disorders, etc. They may need more assessment. But for me, assessment really is about answering referral questions. And I think that after you take a history and you've looked at broad and narrow spectrum questionnaires, which we'll address now, you should have a pretty good idea of what's going on. The face-to-face assessment is really done to better define the related abilities and achievement and mindset the child brings to everyday life. And these are, for time's sake, I'm not going to stick on them, but here are some attributes that are associated with better coping, better outcome, that show up in multiple studies. So when I take a history, I ask for parents about these things. And some parents will say, everybody loves him. He's such a pain in the neck at home, but everybody loves him. That tells you something about this kid, right? Even reading skills have been found to be a protective factor. Humor is a protective factor, believe it or not. Locus of control, which was once very popular. We go back roughly 30 years. With every kid we evaluated, we talked about locus of control. Now I rarely see it. Here's some environmental factors that are associated with better coping. I'm not saying that everyone has to have a small family, but smaller family size may mean parents have more time and resource to address issues. So you can look at those. And again, as I take a history, I'm looking at those protective factors because they will reduce the probability of an adverse outcome. And it's not a magic bullet. This is not magic. Having a charismatic adult in your life that cares about you, having the opportunity to develop an island of competence, a term Bob and I use to refer to something a child does that helps them feel capable, living in a safe environment, learning how to manage your impulses. All of these are powerful predictive factors over time. Now, just quickly, how the brain works. This is how I explain it when parents or teachers ask. I talk about ability, knowledge, and skill. So abilities are hardwired, not that biology is destiny. It just affects probability. We look at 4 basic abilities in a Lurian model. I'll talk about that in a minute, but planning, attention, simultaneous or critical thinking, and sequencing. Most children with language-based learning disabilities have trouble with sequencing. Children who have limited intellect, limited critical thinking, have trouble with simultaneous ability. Children with ADHD have trouble not so much with attention to detail, but with planning, believe it or not. And children with autism in our neuropsychological testing have trouble with attention. They just don't know what to pay attention to, whether it's a social activity or any other activity. We're developing a new series of tasks with children who have autism to be used to help create an intervention plan for them. And so we look at a variety of capacity to pay attention to relevant detail and find that children with autism have a very difficult time. Knowledge is anything you learn by experience. It's not just language. Everything is, it's not just academics or language. It's anything you learn. And finally, skill is the efficiency with which you apply it. So from an ability, knowledge, and skill perspective, a child may have average abilities, sequencing, association, have average reading knowledge, but be skillful in school and earn good grades because they work hard. Another child may have strong coordination as an ability, be a good athlete in terms of their knowledge of the sport, but not be skillful in competition because they're nervous or impulsive. So that's how I explain it to parents. Here's the components of a thorough assessment, which we briefly touched on, and we'll look at these instruments here. Let me go back. What do I use for impairment? I use my instrument, the RSI. Russ Barkley has one. I think you buy it and then you can copy it. I don't know if there's a computer analysis for it. I used REF measure, the CEFI. You might use the brief. Or I think there may be one other in the marketplace now. George McCloskey may have one. And for risk, I use an instrument that I mentioned, the Risk Inventory and Strengths Evaluation, that looks at interpersonal strengths and environmental risks. So it's kind of a balance between the two. I will tell you that what's not on there is the ABOS or the Vineland. And if needed, I will use those. It's more often I will use those to assess children who I think are lower functioning or delayed developmentally. How do we make a distinction between impairment and adaptive functioning? And if you use the new ABOS, the instruction is if the child doesn't know how to do the behavior, you score 0. That's lack of adaptive behavior. If they can do it but don't do it consistently or effectively, then you give them a Likert score, and that's impairment. So adaptive behaviors, do you know how to do it? Impairment is, do you actually do it? And I think that's why Tom made that adjustment when he created the ABOS. We had quite a few discussions over the years about the difference between impairment and adaptive functioning. And again, broad spectrum questionnaire, I use the Conners. That's the broad spectrum Conners. Down below where it says, disruptive problems, we can use the Conners 4, which again is a disruptive disorder instrument, not the full Conners. We can use the ASRS, our autism scale, the MASC, which is a very good anxiety measure, the CDI, which I think is a very good measure of behaviors associated, Maria Kovac's instrument, associated with depression. We have a questionnaire for teachers that looks at ability, knowledge, skill as well, the CAS questionnaire. And then, do you need achievement testing? Do you need to give a full CAS? Do you need to give a Kaufman? For me, it's not as important you give a test, but that you can answer the question. So if I ask, do you think this child's difficulty is the result of knowing what to do and not doing it, meaning poor impulse control, or do you think that this child's problem is the result of they really don't know how to do it? And if you can't answer even that question, it's hard to go much further in terms of designing intervention. So there are many circumstances where you need to know a child's level of critical thinking, their ability to plan or initiate. And you can even use the Woodcock cognitive, which I use sometimes, to get at some of those abilities. I think you want to measure resilience, meaning the child's or adolescent's mindset about how hardy they can manage stress, how well. The RISE gets at that for kids down to age 9. The resilience scale, which the late Sandra Prince Embry developed, I was pleased to assist in that and write a foreword to her manual. She's since passed away. That too is a good instrument, but you have to have some measure. I think there are a couple of others. You want to know about personality? What do we say about personality? We say, well, personality is different from mental illness, because if you have a mental illness, it bothers you. If you have a personality disorder, it bothers everybody else. Personality is a set of filters you use to screen the world. If you have a personality disorder, it means the way you're screening the world is causing problems for other people. So I think you need a thorough history. I'm going to skip over that for the moment. Those of you that are interested, I have a history form. If you email me, I can send you a copy. I don't sell it any longer. I make it available. I just ask that you not take my name off it if you use it. It's an organized way of taking a history. I send it to parents ahead of time and ask them to complete it. So all of my evaluations start with a broadband tool and a history. Increasingly in the clinic, given the population I see, I start with a broadbands tool and a history form, but also an executive functioning measure and an impairment measure. And then from there, I then make a determination as to whether I need any of those narrow band tools. So that's how I organize my history. So here's impairment. I think I mentioned, look at this. The relationship between symptoms and functioning is unexpectedly weak and bidirectional, meaning one drives the other, or sometimes the other drives the first one. So symptoms don't always predict impairment. You have to ask about impairment. With IDEA, you have to measure impairment. We talked a little bit about what it is here and what might contribute to it. We just talked a minute about a difference between adaptive behavior. I'm going to skip over that. Again, using utensils versus not using them to eat when you know how to use them. And I think you can have impairment absent any formal diagnosis. So you can have impairment even without meeting diagnostic criteria. There's our impairment scale. It's a fairly brief scale. Do you know the first scales that were created were specifically designed like laundry lists, just asking, does the child do this, yes or no? Eventually, we created Likert scales. How much does the child do this? Eventually, we realized we needed normative data. So we collected what is normal, supposedly, but telling you what is normal doesn't tell you what is being measured. And then we started doing factor analysis, first confirmatory. Do these items in the scale actually predict each other? And then what's average for different ages? But even that falls one step short, because a confirmatory factor analysis puts items together and demonstrates they go together. It doesn't just let the statistical analysis examine all symptoms and tell you what items go together. And all tests now start with an exploratory factor analysis, putting all of the items into the computer, because the computer can generate high-level statistics, compared your answers to 300 other ones of your answers to 3,000 other people, and have some idea of the incidence and prevalence of a particular symptom and its occurrence in an algorithm in the condition. What's the probability the symptom will predict? And when you look at the evolution of scales, we started with few questions, eventually got to scales with hundreds and hundreds and hundreds of questions, eventually added more narrow band scales because we realized that the broadband isn't enough. Even my dear friend Cecil Reynolds has acquiesced that if you're evaluating autism, the BASC is a good place to start, but a narrow band tool like the ASRS really is the best place to finish. And so after having that evolution of instruments with lots and lots of items, we now try and create instruments that are predictive, but with fewer items. And as you can see for the RSI there, that's what the scale looks like. 41 items for the parent form, for the younger version, 49 items for the older. We did an exploratory factor analysis, looked at how the scales fall out. That's the teacher one, because it asks fewer questions about outside of school life. You can see the scales there. And what we did was, for example, with the RSI, look at the teacher scales. The teacher can't tell us anything about domestic or family, for example. We started with quite a few items and gradually reduced items until we had a scale of the fewest items with the best prediction as to how much impairment the child had based upon the comparisons we used to prove that our scale really measures what we say it measures, and you can have confidence in using it. And so there's the two sets of items. And so less is better, we realize, because we're giving parents so many questionnaires to complete. It's always a dilemma. I give a broad spectrum instrument to teachers and maybe an EF instrument, but I rarely give narrow spectrum instruments to teachers. Take a look at this scale. It answers the question, what does impairment measure? And if you look at the correlation there, you you double the correlation. So how well does impairment measure adaptive behavior? 0.5 times 0.5 is 0.25. There's only a fourth of the variance that overlaps. Look at social emotional functioning on the Devereux, 50%. And that makes sense. 50% of what you measure on impairment is measured on the Devereux. Look at executive functioning, 0.78. Look at psychopathology, not much. And look at ability, hardly any. So what you're measuring, what this tells us is that you have to give some kind of an impairment scale. Whether you use mine or whether you use another one, you need to give some kind of an impairment measure, because what you're measuring on the impairment scale is not measured in any of these other tools. Now, quickly, executive function. What is it? Oh, it's become so popular. Our textbook, the textbook that Jack and I edited, we invited contributors to offer chapters about their view of it. And there are dozens and dozens. From a statistical point, the question is, what is executive functioning? Is it lots of behaviors? Is it one behavior? Is it an outcome? Is it a process? Is it plural or singular? So what we did, as we did the CEFI, we asked what's being measured in an exploratory factor analytic way. We took all the items, put them in the computer, and said, tell us the very best explanation for these data. Is it one factor? Is it two factors? I hope people understand this. If not, go take a look at sort of what a exploratory factor analysis tells you. But what we found was that there was just one factor, whether it's the parent or the teacher or the self-report on the CEFI, and that's called a scree plot. And as that number, that eigenvalue goes down to near zero, that tells you the best explanation for the data. And you see that one factor, for example, is 10 times better explanation in the eigenvalue than two. So it tells us that really what's being measured here is one thing. Yes, we talk about different behaviors, but in the end, they really coalesce into one phenomenon. So what we did then, when we took the second half of our large normative sample, matched the census, and we artificially created scales, 9 scales of the most common behaviors that are referred to as executive functioning. And we used confirmatory factor analysis to prove the items in those scales really predicted each other. And then we again did an exploratory factor analysis, and it was even more powerful. Look at that parent form, 1 factor versus 2, 7.5 to 0.2. That's a 35 times difference. Very clearly, executive function, not functions. Very clearly, executive functioning is how efficiently you do what you decide to do. And I point out the orchestra leader there as an homage to my friend Tom Brown, who talks about how an organizer, in this case a conductor, helps all the members of the orchestra work together. So executive function is one phenomena, how you do what you do, comprised of a lot of behaviors. And yes, on a single child basis, one child may be better at planning and poor at emotional regulation. Another child may have better emotional regulation, but poor at planning. But when we aggregate them into a large sample, those differences wash out. And if we look at executive functioning, again, as a mediator, as a catalyst, just think about how efficient and strategy helps you think critically, helps you acquire knowledge, helps you efficiently do what you decide to do. Right? So executive function is an overarching phenomenon that very clearly plays a significant role. And I showed you the statistical analyses that for behavior, what's measured in a Conners questionnaire or what's measured in a Roberts apperception test, not at all measured in a measure of impairment per se, or an EF per se. So again, very clearly, executive function is that variable in between symptoms and impairment. Better executive functioning, less adverse outcome from impairment. I think it's essential for daily life, for academic and occupational functioning. There are some studies. I think it's essential for pretty much anything we do. So now, as evaluators, so what have I suggested? You start with a history, you start with a broad spectrum questionnaire, gets you in the ballpark about disruptive and non-disruptive problems, gets you in the ballpark about symptoms that may load on certain diagnoses or eligibility determination, gets you in the ballpark on certain kinds of behaviors that can cause problems or may insulate or protect the child from having more problems. And now I've suggested that you really do need a measure of executive function, you really do need a measure of protection, of resilience, and you really do need a measure of impairment. So those three, I think you have to have some way of addressing it. If you think you can address it narratively by taking a history, fine. If you have a series of questions that you like to ask that you believe help you do it in a reasoned and reasonable and reliable and valid way, go ahead. I think a questionnaire is the simplest way to do it. And then just quickly, I like showing this. At every age, girls are more efficient than boys. Not only are they better critical thinkers, but they have better executive functioning across the board. And that's why we need gender reported differences. And you can see a difference in gender differences. It isn't so much in critical thinking or sequencing, it's in planning and attention that girls clearly function better. And executive functioning clearly influences, and I've got about 10 minutes here, so I'm going to jump a little bit, but this is a complicated slide with a lot of data. What I just want you to appreciate is that how you do what you do influences your full scale IQ, it's 16% of the variance in how you do what you do. An example I can give you is a child I was testing the other day on the WIPSI, and he wanted to put the blocks over the picture. And of course, you can't let him do that, but I did let him kind of match them up. That strategy improved his performance. And when you multiply those numbers by themselves, it tells you the variance in which strategy improves performance. Look at flexibility. So for the full scale WISC-4, flexibility, 25% of your performance on the WISC was contributed to by being flexible. Here's data for the CAS, and here's data for the Woodcock. Look at that. A very high percentage of the variance, particularly reading and math, is determined by the CEFI and written language. So how you do what you do. And there's the our CEFI, there's the 9 areas that we measure. And this is the RISE that measures, is the first instrument that measures both protective factors and risk factors. And I can tell you that no matter how you measure resilience, which is a process, not a product, that you always get 3 factors. Different scales call them different things. The resiliency scales calls them something else. I think the brief may call them something else when it looks at protective factors. I think it does in terms of metacognitive index, but here the RISE looks at, we call it emotional balance, interpersonal skill, and self-confidence, and then it measures risky behaviors. So it compares the youth's response, this goes up to age 25, compares the youth response to a sample that we collected of children in treatment for certain challenges. So these were kids who were in treatment for, say, delinquency or for substance abuse. So it gives you a probability statement. What's the probability that this child's responses or the observations of a parent or teacher place this child at risk for significant challenges in these areas? And there's an overview of the RISE. For time's sake, I'm going to skip through it. Here's the Connors, which is the broad behavior instrument that I use. I really like the early childhood. I like the way it's designed. I like the circular graphic, a unique way of looking at strengths and weaknesses. I like the developmental perspective as opposed to the labeling perspective. I like the broad Connors because I think it really separates out patterns of behavior that cause impairment from patterns of behavior that lead to diagnoses. Keith will be sorely missed. I had the pleasure of founding the Journal of Attention Disorders with him, and I learned a lot from him. He was a fascinating man who developed an instrument out of a need. He'd come back from England where he was a Rhodes Scholar. He got a job as a research assistant for a psychiatrist doing a medication study, and they needed some kind of a measure to determine whether the medicine was helpful. And he developed the scale, which in the beginning was just a laundry list, and eventually came to be known as the Connors. In the early years, it was given away, it was free. Keith once lamented that if he had a penny for every Connors that we gave away, he would have been a billionaire. Eventually, he signed the rights over to Steve Stein at Multi-Health, which really allowed for a much more complex and broad development of the tool. The early childhood, I think, is the best early childhood tool available. There's the early childhood tool. Most of you are aware of it. You can see the content scales and the DSM-5 scales. Again, keeping in mind that crossing a DSM-5 scale, having a high T-score doesn't necessarily prove you have the disorder, but that you demonstrate behaviors that are characteristic of the disorder. And then there are other clinical indicators that I think are very valuable. And then the new Connors, which would be a narrowband tool if the child demonstrates patterns of disruptive behavior. The new Connors is there. And it looks, as you can see the table there, it's looking at disruptive, not internalizing behaviors. And that emotional dysregulation scale, I think, is a very good scale to make a determination as to whether you should give a DMQ, which again, for time's sake, I'm not talking about today. But if you're concerned the child has emotional dysregulation, has a long emotional dysregulated outbursts, is irritable, you have to walk on eggshells around them, that loads into that scale, and that's what DMDD is all about. And then non-disruptive, there's our autism scale. Most people are very familiar with the ASRS, which has a young child and an older version. The ASRS, as you can see, the top is parent-teacher, the bottom is parent-teacher clinical, and you can see how well the SRS distinguishes children with autism. Questionnaires don't diagnose, they distinguish, but children with autism from the general population and from children with other clinical problems. The SRS is a narrowband tool. It's not designed to identify other problems, although look at where the two cross, kids with ASD, kids with ADHD, there's two spots they cross. The one spot is attention, the other spot is self-regulation, which is why 2/3 of kids with autism meet ADHD criteria. This is the mask, which I think is also my go-to tool, John March's tool. If you don't know the mask or are using one of the other anxiety instruments, I would encourage you to take a tour of it. I like the way it breaks anxious behaviors into categories. I like the printout. I like the probabilistic statements. This is depression, Maria Kovacs. I like Maria's way of assessing depression. And again, I find it very helpful to explain to parents that some children with depression may not have negative self-esteem or may not have interpersonal problems. So I like the idea of looking at functional versus emotional problems. And there's a description of the scales there and the CDI self-report that teens can fill out and the profile. There's the CAS, which I briefly touched on, planning, attention, simultaneous or critical thinking. There's a brief CAS. I showed you this data in which kids with ADHD perform poorly on planning, kids with autism perform poorly on attention, kids with learning disabilities, particularly phonemic-based learning disabilities, score poorly on sequencing. And then I try and organize the data. When I talk to parents, I talk about a day in the life of your child. I make a distinction between ability, knowledge, and skill. I take a chronological perspective, understanding where the child is, where they end up. I really focus on protective factors. We look at eligibility, although if I'm not in the schools, I make suggestions, but I never tell a school whether a child is eligible or not. That's up to them. The data should tell me about diagnoses. The data should tell me about recognizing needs. The data should tell me about continuing services. And just as a final point, I think your mindset needs to be this. When a child is struggling to learn to ride a bicycle, we don't give them a bicycle riding test. We don't send them to the doctor to be evaluated, assuming that there's nothing seriously wrong with them. We accept that slow is fast enough. We accept that some children need more practice to build proficiency. Two mandates, two ideas that I've based my practice on. Slow is fast enough, and some children need more practice to build proficiency. And when a child struggles to ride a bicycle, we just help them get on. We try and be affirmative and supportive, and we keep on getting them on the bicycle. And yet when they struggle in other, quote, high stakes areas, learning to read, to socialize with behavior, we're quick to pathologize, we're quick to demonize, we're quick to moralize. And in doing so, I think we fail to appreciate the real value of our data. The real value is helping us see the world through the eyes of that child. That's the ultimate goal. And in seeing that world, we're in a better position to help that child and to advocate for that child with stakeholders, what's needed and why. Your discussion in a team meeting at school, in a clinical setting with parents or teachers, your discussion should never end with, so he's eligible, or so he has that diagnosis. It should never end with that. It should end, and it shouldn't end with just here's what we're going to do. It should end with a discussion so that all stakeholders understand why the child's struggling, where the child's strengths are, and what kinds of things can be done to help them. If you have questions now, we will entertain questions. I apologize for my cough today, my somewhat frenetic presentation. I like to do this talk in 3 hours as opposed to an hour and a half. Thank you all very much. If you scan that QR code, it takes you to my website. I have a couple of TED Talks. That's the one I did about resilience. So again, thank you all for attending and participating. I'll answer all my questions if you email me. And thank you for MHS for giving me the opportunity for doing this. And I will say that send in a question, and MHS will pick the 3 questions they think are the most relevant, and I will send those 3 people a copy of one of my new books. So thanks very much.
So the first question, Dr. Goldstein, is there a clear difference between CEFI and Brief 2, and how to use them in different situations? Any examples of the case where we should use CEFI rather than Brief 2 or vice versa?
Well, it's an interesting question, but to answer the question, I'd have to assume I'm an expert in the Brief 2, which I am not. I do think it's a viable tool. I think users have to understand how it was created, how the norms were standardized, what the scales actually tell you. Dr. Naglieri and I, in our work together in creating instruments, have always sought to create tools that are fairly straightforward so that both the user and the consumer understand. So we've avoided complicated terms like metacognitive index, and instead spoken the kinds of terms that both clinicians, planning, attention, organization, that both clinicians and the lay public, the consumer, a parent, a teacher, or an adult would understand. With that being said, I'm not going to advocate that one is better or worse. I think it's really up to the individual. I don't know that there's a better a population or better circumstance to use one or the other for that matter. I think it's a matter of preference. Obviously, we would appreciate if everyone used the CEFI, but if you find that another tool is better suited to your needs, I think that's fine. But I think, as I said during the presentation, you have to today have a measure of executive functioning. You have to have a strategic measure, because strategy, as was pointed out, is up to 20 to 25% of performance. Jack and I have very clearly demonstrated that the scales on the CEFI are very predictive of performance, even academic performance on, say, a woodcock. So it's not enough now to just give broad spectrum tools. You have to give a measure of executive functioning. So I would leave it up to the individual. I think our tool is straightforward, easy to understand, and easy to explain to others, and very well validated statistically.
Well, thank you for the fair answer, Dr. Goldstein. The next question I have is looking at the comorbidities chart, I'm wondering what your thoughts are about the utility of differentiating between ODD and pathological demand avoidance in children are on ASD or ADHD spectrums.
So, pathological avoidance demand syndrome is not in any diagnostic manual. It's a term that's become very popular, came from Britain. I was just in London speaking, and it's a term they're beginning to use, but it is not in any diagnostic manual. And so it's difficult to compare uh, a descriptor like that. I'm not saying it's not valid, but it hasn't been examined for its reliability, the descriptors that go into it, the populations that present it. It's become very popular to suggest that it's characteristic of autism and or maybe ADHD, although what I've heard and what I heard a week ago in London, really they're looking at it as it relates to um, autism. And even the term, I haven't spent a lot of time studying it, but the term bothers me. Pathology, I think we're moving away from the use of that term. Um, Avoidance, meaning you're trying to get away or avoid doing things. And the term syndrome, or the term demand, as a descriptor, it's hard to know exactly what that means. If I said to you, what does this mean? I think people are going to have a hard time. So I really don't have an answer for where do those kinds of behaviors lie. I'm sure people have opinions and I'm sure people have beliefs, but I feel some responsibility to not offer a belief or opinion, but to answer a question with some foundational science for which, as far as I'm aware, for pathological avoidance demand or demand avoidance syndrome, I don't have any.
The next question I have is would assessing ADHD using cognitive measures in an adolescent with depression affect the accuracy of our results? Should we wait for him to be emotionally stable through psychiatric intervention?
So I'm not sure what kind of measurements we're talking about. If we're talking about a Connors CPT, that's one thing. If we're talking about subtests on the cognitive assessment system or the Dallas Kaplan system or behavioral observations, I think it varies. I think that individuals who feel helpless or hopeless, it does affect their persistence. It does affect their stamina. As tasks become more difficult, they may be quicker to quit. Running high levels of cortisol may adversely impact in a neurobiological way an individual's capacity for attention. So this kind of a difference might show up more on sensitive measures like a Connors CPT. It might actually lower the score somewhat. But for me, the question is, what are we trying to prove? What are we trying to demonstrate? If we're trying to demonstrate that the child has both depression and ADHD, those are diagnoses based on a set of symptomatic criteria, not based on a test score or test performance. When it comes to executive functioning, of which attention is a component, yes, we know as we've demonstrated in other presentations or in other uh, studies that uh, executive functioning, of which attention and planning are components, will be negatively affected if someone is depressed or anxious or has autism. So for me, it's an issue of what am I trying to prove by assessing the child's level of attention? And if you're trying to suggest, well, maybe this child has depression and ADHD, then yes, I would try and treat the depression, whether it's psychologically or pharmacologically or both, and then see how the child functions over a period of months, and then try and go back and determine, well, is there a rationale for any further assessment looking at ADHD? But ADHD and depression are two very different conditions with two very different etiologies.
Thank you, Dr. Goldstein. I have two more questions. So the second last is how does the CEFI complement the CBRS? And in what context are they most effectively used? And also they asked how can they purchase these assessments?
Well, purchasing I will leave to you as the marketing department. I think a tool like the Connors Behavioral, which looks at the disruptive continuum, is in many ways a broad symptom questionnaire because it's looking at a broad range of behaviors and possible diagnoses. The CEFI is a narrowband tool specifically looking at executive functioning. I increasingly advocate, as I mentioned in response to an earlier question, that we give a measure of executive functioning all the time. So now it's a broad spectrum tool and a measure of executive functioning. And in fact, I give a broad spectrum tool a measure of executive functioning, our rating scale of impairment, and some kind of a protective or resiliency scale like the RISE or the resiliency scales, because I think that tells us something about the child's stress hardiness. But I don't think that they're exclusive, and I do think they're complementary in the sense that some of what's measured on some of the scales in the Connors are measured by the CEFI and vice versa, but the majority of what the CEFI is measuring is not informed by giving the Connors behavioral rating scale.
Here is the last one. Do you recommend the CBRS and Connors 4 when ADHD is the primary concern? Or do you believe that the CBRS gives adequate information for diagnostic and treatment purposes?
So let me make sure I understand the question. You're asking, is a broad spectrum questionnaire sufficient for evaluating a child when you suspect ADHD as the primary problem? And I would answer no, that a broad spectrum questionnaire is exactly that. It's the first step in trying to understand the particular patterns of behavior. And again, not every behavior is a symptom. All symptoms are behaviors, but not every behavior is part of a diagnostic disorder. And the great advantage of broad spectrum tools is we ask a lot more questions than just the symptoms. We ask about a broad range of behaviors that downstream can be affected by the symptoms, and questions about those behaviors are not typically asked if you're just asking about symptoms. So I think you start with a broad spectrum tool, and if that tool on an ADHD scale or an autism scale or an oppositional scale or a conduct scale or a depression or anxiety scale, if that tool gives you cause to be concerned, then you give a narrow spectrum tool. And I do understand that it's a lot of questionnaires for parents to fill out, but it is increasingly a gold standard way of gathering data from stakeholders who observe the child on a daily basis. There is a reason why our face-to-face tests, measures of executive function or attention, for example, why those face-to-face tests, they measure behavior, but they're not very predictive in telling you whether someone has a diagnosis or not.
Well, this is it. Thank you so much, Dr. Goldstein, for the informative presentation and joining us today for the question and answers. I would also like to thank all our attendees who joined us. If we did not get to your question in this webinar, then please send us an email at marketing@mhs.com and we will forward your questions along to Dr. Goldstein. As a reminder, you will receive a copy of the webinar recording in 7 to 10 business days. On that note, we are at the end of our webinar and I wish all of you a nice rest of your day.